We know that in acute myeloid leukemia, AML, FLT3 mutations are reported in around a third of the patients. Mostly they consist of ITD mutation, internal tandem duplication, in around 25% of the cases, and tyrosine kinase domain mutation, TKD, in 5 to 10%. And patients with FLT3 mutation usually have a poor prognosis. They have a worse relapse-free survival, overall survival. This is slightly changing with the function of FLT3 inhibitors, and now more and more with combination therapies. And about 75% of patients with the FLT3 ITD mutation at diagnosis, those patients maintain and conserve the mutation at the time of relapse. And therefore, we consider the FLT3 mutational status as unstable. For example, patients with wild-type FLT3 disease at diagnosis can relapse with a FLT3 mutated disease. And this is reported in about 7 to 20% of the cases in previous studies. On the other hand, and this is less common, patients with FLT3 mutation at diagnosis could also relapse potentially with a FLT3 wild-type disease. And that was the aim of our study, to evaluate the change of FLT3 mutational status between the time of diagnosis and relapse. So therefore, for our study, we identified 1,231 patients with newly diagnosed AML at MD Anderson between October 2008 and March 2020. And we excluded patients who did not achieve a proper CR or CRI. By this, I mean patient with partial response, patient with MLFS were excluded. Patient in continuous remission who did not relapse were obviously excluded. We also excluded patients who didn't have the FLT3 status at diagnosis or at relapse, meaning one of them was missing. And patients with FLT3 testing beyond 4 weeks from the time of relapse were also excluded. We ended up with a total of 342 patients that were included in our analysis. Patients were divided into two big groups: those who were FLT3 at diagnosis wild type, and those who were FLT3 mutated at the time of diagnosis. And those patients, each of those groups were divided also with regard to the FLT3 mutational status at the time of relapse. The median of our study study population was 64 years. Most of the patients had intermediate risk disease, 55%, or poor risk disease, 38%. By ELN risk group. Most of the patients, as we all expect, had ITD-only disease, which is the most frequent subtype, 72%. And if we take a look at the FLT3 ratio, allelic ratio at the time of diagnosis, we can see that the highest allelic ratio was observed in patients who had FLT3 mutation, both at diagnosis and at relapse, with a median of 0.41 and up to 0.76. Which means that those patients really had a high disease burden and FLT3-driven disease. Then analyzed the relation at the time of relapse and the occurrence of any specific molecular mutations detected by next-generation sequencing panel, NGS. We saw that if let's take first the group of patients who had a FLT3 wild-type disease at diagnosis. Those patients who relapsed with a FLT3 mutated disease had a higher incidence of NPM1 mutation, NRAS mutation, and CEBP alpha mutation. On the other hand, we take the group of patients who had a FLT3 mutation at the time of diagnosis. Those who relapsed with persistence of FLT3 mutation had a higher incidence of NPM1 mutation. We didn't find any other difference in molecular mutation in this second group of patients. Now, among the 237 patients who had wild-type diagnosis, 14 patients relapsed with a new acquired FLT3 mutation. 9 of those had ITD, 5 had TKD mutation. One of those 14 patients had a prior stem cell transplant, and one of them had a prior sorafenib therapy. And therapy was given as part of a multi-kinase inhibitor therapy, not as a proper FLT3 inhibitor per se. 10 patients had diploid cytogenetics at diagnosis. 6 of them remained diploid. 1 relapsed with KMT2A rearrangement. 1 had complex cytogenetics and relapse. 1 had trisomy 8, and 1 had other cytogenetics. For 5 of those 14 patients, we had NGS molecular testing done both at the time of relapse and at diagnosis, and we have observed 9 newly acquired mutations in NPM1, KRAS, RUNX1, IDH2, DNMT3A, ZRSF2, WT1, and STAG2 mutations. We're going to summarize what treatment and outcomes those patients had. Half of the patients were treated with low-intensity therapy, and half of them was high-intensity therapy, obviously. Sorafenib was the most frequently used FLT3 inhibitor, and 73% of the patients who used FLT3, followed by quizartinib in 13%. Venetoclax was used in 14% of the patients. Our complete remission rate was 78%. Interestingly, if we look at the duration of remission, we can see that patients who had FLT3 wild-type AML at the time of relapse, regardless of their status and diagnosis, those patients had a remission duration of about 8 to 9 months. On the other hand, patients who relapsed with a FLT3 mutation, again, regardless of what they were at diagnosis, those had a shorter duration of remission, about 6 to 7 months. Now, if we take a look at the survival of our patients, and the median follow-up of our study was 8 years. Total overall cohort, the median overall survival was 17.4 months. The 5-year overall survival was 12%, and the 8-year overall survival was 8%. Observed that the worst survival was seen in patients who had FLT3 mutation relapse, irrespective of the status of diagnosis. For example, if we take patients who had wild-type disease at relapse, whether they were mutated or not at diagnosis, those patients had a median overall survival of 18 to 20 months. On the other hand, patients who had FLT3 mutated disease at the time of relapse, those patients had a median overall survival of 13 to 15 months, regardless if they were mutated or wild-type at the time of diagnosis. What are the take-home messages from my presentation? First, FLT3 mutations can occur at the time of relapse, even in patients who had FLT3 wild-type disease, and this is about 6% in our cohort. Those patients had a higher incidence of NPM1 mutation, NRAS mutation, and CEBP alpha mutation. And they can also acquire clonal evolution and acquire new genetic mutations at the time of relapse. Patients who had FLT3 mutation maintained between a diagnosis and relapse, those accounted for about 65% of the cases. They had higher incidence of NPM1 mutation, shorter remission durations, and a worse survival compared with other groups. So patients who have FLT3 mutation, both at diagnosis and relapse, they had a very poor overall survival with a 5-year rate of 4%. FLT3 mutational status, in conclusion, can change between diagnosis and relapse. And this is why it's very important to check for FLT3 mutation at every relapse, irrespective of what was the FLT3 mutational status at the time of diagnosis.